good evening, everyone. It's my pleasure this evening to welcome you to the 7th installment of this Fireside series, part of the AO Trauma North America opportunity for us to work through some difficult fracture problems together. Tonight, we're going to talk about trans-olecranon fracture dislocations as well as Monteggia fractures. My name's Chad Coles. I practice in Halifax, Nova Scotia. It's my pleasure this evening to be joined by two talented surgeons as well as great educators, Andrew Chu from UT Health and McGovern Medical School in Houston, and Samir Mehta from Pennsylvania University in Philadelphia. Prior to this evening, all of our potential disclosures have been resolved. We have nothing that conflicts with the content this evening. And our agenda this evening will be similar to what we've seen for previous firesides. After this introduction, we'll look at some cases, first of trans-olecranon type fracture dislocations. We'll have a discussion, move on to some Monteggia variant cases, followed again by some discussion. And then we'll review a classic journal article, talk a little bit on its relevance and how it's impacted our understanding of these injuries and perhaps some things that we do differently today. And then we'll summarize, again, aiming to keep this somewhere between 75 and 90 minutes. Learning objectives for this evening are for you to be able to evaluate radiographs to determine the injury pattern, to be able to describe a reduction sequence, as well as a strategy of how to achieve that reduction, and then ultimately to be able to select appropriate implants for management of these complex injuries. So here's the challenge. This is a 23-year-old who's involved in a motorcycle collision. I think we can all recognize that this is an elbow fracture dislocation. It's not a terrible triad. So if you tuned in tonight looking for triads, you're going to be disappointed. That'll be on the 29th of June. But tonight we're going to talk more about, again, the trans-olecranon fracture dislocations and the Monteggia variants. And you see this injury, and unless you have an approach to this injury, a way to make and develop a plan of assessment and treatment, these can be sometimes terrifying injuries when you see their initial radiographs. And I think what you'll come to appreciate is that it's a spectrum of injury. It's not just one fracture pattern. Each of these, although they have some similarities, they also have some differences. And you need to spend some time looking at the injury pattern to develop your preoperative plan. Again, we'll look at two fracture patterns, the trans-olecranon fracture dislocation and the posterior Monteggia fracture. So the trans-olecranon fracture dislocation, originally published in the French literature, but really popularized by Ring and the group from Mass General. And what we see here is that distal humerus is driven through the trochlea. We often get some significant comminution of the trochlea and of the olecranon. You can appreciate that this is not going to be a simple olecranon fracture to reduce. With that, we get anterior dislocation of the radius and ulna. So the forearm dislocates anteriorly and typically as a unit. So what we see is that the proximal radio-ulnar joint stays reduced, typically. If we contrast that with the Monteggia fracture, this was named by Monteggia back in 1814, who recognized that with a fracture of the ulna and an anterior dislocation of the radial head. And this was then subsequently subclassified by Beto in the 60s. And what we're going to be focusing on tonight is mainly the type 2 injuries, not with a simple forearm fracture or a diaphyseal ulna fracture that you see here, but more what was described by Jupiter. And this is a classic paper from '91. We'll discuss this later as part of our journal review. But this is where Jupiter recognized that these posterior Monteggia fracture dislocations are different actors. So really, it brings a little bit of a question of, are these really two distinct fracture patterns? Sometimes the bones don't read the textbooks. They don't necessarily follow the classifications perfectly, but it's important to try to identify the injury pattern so you have an understanding of the mechanism. But what you'll also see from these is that they also have some significant similarities in how they're treated. The goals with both of these injuries are to restore articular congruity, to restore joint stability, and ultimately to be able to permit early range of motion to avoid stiffness. All of these are lofty goals with these complex injuries, and to help us figure out how to get there, again, I'm joined tonight, for those of you who are just joining us late, Samir Mehta from Philadelphia and Andrew Chu from Houston. who are going to share with us some cases of trans-olecranon fracture dislocations.
Okay. Thanks for that introduction. We'll go ahead and get started. Good evening, everyone, or good morning, good afternoon, depending on where people are joining from. The first case I have is this 29-year-old right-hand dominant female. She was roller skating and fell on her outstretched arm. These are the x-rays we get in the emergency room when she comes in. Chad, you're on mute.
Andrew, when you look at that, what are your initial thoughts looking at these injury radiographs?
So I'm looking at the thing that obviously jumps out is you have an anterior lateral dislocation of the radial head from the capitellum. You have a comminuted proximal ulnar fracture. I'm looking at maybe is there a separate coronoid fracture, but it does also look like there's probably dissociation between the proximal radial ulnar joint as well. So those are the kind of things I'm looking at briefly.
Yeah, I mean, I think you bring up a good point, Andy. I didn't really appreciate this fragment here. I don't know if I just assumed when I saw this long sort of spiral oblique type fracture of the olecranon that was associated with my radial head component, but there appears to be a separate piece here, and I didn't realize that until I was in the operating room and starting to fix this, that this was a separate fragment. And when I see this fragment, sometimes then I wonder, is the PRUJ intact, in the sense that the soft tissue attachments between the radial head and this piece, and then if I get this piece back, the radial head should come with it, I would think. But maybe I'm wrong about the way I'm looking at that.
So I think a great example of how sometimes the classifications for these overlap a little bit, and you can sometimes get caught up in the semantics of the naming system. But more, I think, having an approach and identifying as you've identified, there's that fragment that's going to need to be reduced and stabilized to restore stability of the radial head.
Yeah. So
are you routinely getting CTs on these or no?
So that's a great question. I don't find a lot of value in a traditional CT. Like if you showed me axial images of this or sagittal images of this, the elbow is always in the gantry in some awkward position. It's never quite the right orientation. The technicians, as great as they are, don't appropriately orient the imaging, and I don't have the bandwidth to be able to try and understand poorly done axial, coronal, and sagittal images of this kind of injury. I do, and as I've started to have a little bit more computing power at our institution, I do like the 3D images that I think we'll show a little bit later. I do like those, and I have found those to be more helpful. But traditional CAT scan images, I don't usually do. No. So Samir, a lot of times they get done automatically, but I still don't find them very useful.
When I look at this, Samir, you see the anterior dislocation, lateral dislocation of the radial head. Some people might look at that and start thinking that this is going to be a lateral approach to restore ligamentous stability, to get that radial head reduced. But how do you typically approach these and position them for success? I think this is different than the triad injury that many of us may be more familiar with.
Agreed. I don't look at this as a triad, which I would position differently. I do this in a lateral decubitus position. So there are a couple of nuances that you'll see here. I use a radiolucent arm board. You could also use what people sometimes describe as a quote unquote paint roller or a rounded device. I think in an olecranon fracture, whether you use a radiolucent arm board or one of these paint roller style devices probably doesn't matter, because the fulcrum is not through the fracture. I think if you were doing a distal humerus, I like this flat surface to work on. You'll note that the post for this is coming in from above the head, not on the side of the bed here, and that's important from a C-arm perspective. But this is how I position them in the lateral decubitus. So I'm doing a posterior exposure to the elbow. I still can access the lateral side if I have to, although it's sort of operating sideways. And if I really had to, I could probably access the medial side, although again, all I do is work through large flaps medially and laterally through a posterior exposure. In terms of C-arm imaging, This is the AP image on the left, and on the right, that's how I get my lateral. I would encourage people to not rotate the arm to get the lateral image, like on this left-sided picture. If you rotate the arm up to get a lateral image without moving the C-arm, you're putting a tremendous amount of stress and force across that elbow. And if you have not anatomically rigidly reduced it, your provisional fixation has a tendency to fall apart. And to me, it's not fair to your reconstruction to stress it before you fix it. And by putting it, rotating it into that lateral, for that lateral image, if you're not going to rotate the C-arm like so, is problematic. The other thing, and I pointed this out earlier, the reason I have the post at the top of the bed as opposed to on the side here is as a C-arm rotates up and around, you're not hitting the post of the radiolucent arm board.
Real
So
quick,
for
sorry
me,
to interrupt, Samir.
yeah, go ahead, yeah.
But there are a couple of questions about, to go back to your injury film. Would you tell your residents to try to reduce that?
Absolutely.
Before...
I did not put a post-reduction film in here, but they were able to reduce the radial head and splinter with the radial head reduced, and she stayed like that till she came to clinic. So she was discharged from the emergency room with a reduced radial head. So I would tell them to attempt a reduction, not multiple attempts, but at least one good attempt with good pharmacologic relaxation, so that this patient does not leave the hospital with a dislocated radial head. And so that's how I get our imaging, and for me, this seems to work. I like operating on these from the posterior approach, and I find it harder to do these in the supine position. I know some people will do these supine and put the arm over the body, but in this case, I can do this alone. I don't need any assistance or any devices holding the arm across the body. And then I think from an imaging perspective, it's quite easy for me to get my AP and lateral imaging. This is what the posterior exposure looks like for her. So this is this particular patient, and you'll see some pointed reduction clamps to get the reduction. You'll note that the fracture and the displacement here, I'll go to my laser pointer. You'll see the fracture line right through there, and then some clamps. And this is what Andrew had pointed out really elegantly, but I did not see it until I got to the operating room, is this fragment here that sort of, for lack of better words, surprised me. And I knew I needed to address it, and I had to get to it. So and Andy, I don't know if you would do a separate incision, or Chad, if you do a separate incision to get after that, or try and do it through that posterior incision.
Well, that was going to be my question to you is, now are you regretting putting her in the lateral position now that you think you might need to get around front, or is this something that you think you can approach from the back?
So I think I can get to it from the back. I can take a little bit of muscle down and get to it along the border of the ulna, and I can do that safely without putting, the ulnar nerve you have to think about, but I can do it without putting the ulnar nerve at risk, and I'll show some fluoroscopic images in a second of my access to this piece.
So you're going to sneak around with your tine of your clamp on the ulnar side?
Yeah.
Correct. Okay.
Yeah.
Andrew, anything different that you would do there? How might you get that reduced?
Yeah, I would do the same thing, and I'm a huge fan of CTs, especially the 3D CTs, and I'll show an example, at least one example later, but you can, usually the apex, the most distal extent of that fracture is in a pretty safe area. So if you elevate the ulnar head of the FCU, you can pretty much go around and actually see that reduction and clamp it, and then usually get fixation from posterior to anterior without having to do something separate. So especially for a bigger basilar coronoid that's a one large fragment, this is usually pretty doable just from the posterior side.
These are my workhorse clamps for most olecranon, Montasia, elbow fractures. You'll see that this is I take a traditional Weber clamp that's got two curved tines, and I straighten out tines on the opposite side. So this is, curved straight, and this is a straight curved, and it's because of where the spin down is. So there's a curved part here, and then this is just, I took a pair of pliers and straightened out the one side. It's just a close-up image of that. And then again, not for this particular fracture pattern, but from some of them, I'll put my rounded tines on the olecranon, the tip of the olecranon, and then through a 2.5 or 2.7 drill hole, put my straight tines in the distal segment, and then use that, as I did in this cartoon, to reduce my fracture and clamp it down. And this is a clinical image of a different patient showing the tines in the triceps and the tip of the olecranon. This is the curved tine here, and then through small drill holes, These are the straight tines reducing the olecranon component. But this is a way to potentially get control of your proximal ulna and still have a surface to apply your implants without your clamp or your hardware or your K-wires being in the way.
Samir, I'll tell you that if I did that at my hospital, I would never get those two same clamps in the same set ever again.
Yeah, that's the challenge, right? I do open some sets, and I've got 4 sets of what they call them the meta modified clamps, and so yes, then I'm like, well, I just need a good old fashioned standard Weber clamp, and they're like, we'll have to open another set. I was like, that's great. But then I'm missing those clamps from other trays. Yeah, it happens all the time. So there's a lot of modified clamps floating around my hospital. So this is what you described earlier, Andy. I took a little shoulder hook, and I just wanted to see if I could get there and kind of get it back down, and I could actually palpate and then feel and see my reduction. And you'll see I converted that shoulder hook to a pointed reduction clamp to get my reduction of my my fragment there. And then, just like you said, some lag screws and some independent screw fixation, recognizing that I was going to capture that piece later on as well with my plate application.
And Samir, what size screws are those?
Yeah, so these are 2-4 screws in the ulnar shaft, and then that's a 2-0 screw for that that separate fragment.
And are you worried about those interfering with placement of your plate?
So I like to use longer implants, and so I will typically have plenty of corridors for screw application because I tend to use implants that are longer, but also proximally have smaller screw fixation, which is why I like small diameter or mini diameter screws, because the smaller the screw, that means the more screws I can get into the same density. I use pre-contoured plates for this. We'll hear a little bit about contouring your own plates, but I used a pre-contoured plate for this. One of the big sticking points of pre-contoured plates is getting the plate to be flush to bone. I know that's a pain point for patients. They can feel the plate proud. I also think not having that friction between the plate to bone can lead to potentially instability. And so you'll see here that the plate sits proud. I think your screw sequence is really important for plate application in these fractures. And so you'll see here that I drill a bicortical screw through the plate in a trajectory that's going to allow for 2 different vectors, one that's going to drive the plate distal and one that's going to drive the plate anterior. So I get a friction fit of the plate to bone proximally when I put this non-locking screw in. And I usually use only non-locking screws in these plates. And so you'll see this non-locking screw is down, and you go from that plate being off the bone to the plate being on the bone and getting some friction of that plate to bone proximally in that proximal segment.
So Samir, the triceps insertion is always a bane of my existence there. It's always in the way when I go to put that plate on. Do you have any tips or tricks of how to manage that?
Yeah, so I don't elevate the triceps. I put a split in the triceps, and I put, some people refer to it jokingly as a pita pocket, but I put a little split in the triceps, and I will then put my implant in that split and then repair that split at the end of the case. But I'm not elevating the triceps off of the tip of the olecranon or anything like that.
Okay, perfect.
And that's our post-op final images. My post-op protocol for these, and the majority of my elbows, is immediate full range of motion. I do give them a 5-pound weight restriction. So a cup of coffee, a laptop, a gallon of milk is 7 pounds. They start formal physio at 2 weeks when their sutures are removed, and I make them weight bearers tolerated by the 6-week mark when they come in for new radiographs. Andy, are you doing anything differently for your post-op protocol for these?
No, so for a bony injury with no ligamentous injury or instability, then I will just put a soft dressing. I'll allow them range of motion as tolerated, and I'll for very, very similar to what you're doing there. I don't usually start therapy. I just sort of say patient directed for the first 6 weeks. For those that have an associated ligament injury that I either repair or either with sutures or a bony fragment that I'm concerned about, I will treat them more like I treat an elbow instability case for me, which is usually a splint for 1 to 2 weeks, followed by hinged elbow brace, protected range of motion for a little while. But that's unusual for this kind of injury.
And then when you're splinting them, Andy, because I'm really curious, because I know I'm a bit schizophrenic about my ones with ligamentous injuries, are you splinting them in the position where they're most stable? Are you splinting them in extension, which is sometimes hard to get back? What position are you putting them in to optimize their outcome and your ligamentous repair?
So, I mean, this is a whole different discussion. I usually do about 90 degrees, and typical it's 90 in neutral for a ligament injury. You know, if I'm worried, if I know it's an isolated lateral side, then you could pronate the forearm and try to have the, you know, the common extensor origin on tension, which can maybe help that as well. But typically for me, it's just sort of 90 in neutral, unless there's something, another extenuating circumstance. Distal humerus, I actually split them an extension for a little while just to take the soft tissue, the pressure off the soft tissues. But for a ligamentous elbow injury, it's 90.
Okay.
It's always a trade-off, I think, for stiffness or instability. And the old adage is always you'd rather deal with a stiff, stable elbow than an unstable elbow. So I think you err with these ones on the side of keeping them in a position of stability.
There were a couple of questions about in that injury about sending it home. You know, you said that they were neurologically intact. If they weren't, would that be something you'd send home, or would you do that more urgently, Samir?
If they were neurologically not intact, I would probably
that
do that.
Policy.
I probably, and they were, and the radial head was reduced, I probably would not do it acutely. If the radial head was not reduced, I would not send them home dislocated. But if they had a PIN palsy and they were reduced, I don't think I would, that would not change my timing of, I wouldn't do that more acutely.
Yeah, I think I would agree with that. I think if they had an injury, it's hard to say that, and they're reduced, it's hard to say that that would be made significantly worse than the actual amount of energy that went through at the time of injury. But that's my opinion.
Yeah, I think if they're dislocated, that's a little bit of a different conversation.
Yeah. Should I go ahead, Chad?
Absolutely.
So this is another case, sort of, you know, same story, different chapter. So this is a 28-year-old female. She presented after a motorcycle collision, and these are her injury films. And so first, I guess, Samir, do you think we should even be talking about this in a trans-olecranon or Montasia or fracture dislocation talk, or is this just an olecranon?
Yeah, no, I mean, I think this is not just an olecranon. You know, when I think of it just an olecranon, I think of a nice simple fracture fragment, maybe a little bit of comminution, but you know, this looks like this has potentially fragments that are independent and associated with that of that with that radial head. And on your image on the right, I can convince myself that that radial head is not where it needs to be. And maybe even on the lateral, it looks like it's starting to ride high. So at least for me, this is not just a simple olecranon fracture. It may become one as you start to rigidly fix it, but it's not looking like a typical olecranon to me, no.
Yeah, I bet if you stress this injury intraoperatively, you can make that elbow dislocate anteriorly like we see with the typical trans-olecranons. It's a static image, but I agree with Samir. You can appreciate, I think, on that lateral image that radial head is trying to head anterior, and with a little nudge, I bet it goes the rest of the way. Also, looking at the olecranon, I think you can appreciate that this is impacted. This is not going to be a simple, straightforward olecranon to reduce. There's often a lot of comminution and impaction here, and that's what makes these trans-olecranons, I think, more challenging to reduce.
So I'm a huge fan of CTs for these injuries, and I like what Samir was mentioning. I think that the 3D CTs are actually quite helpful, sort of getting you a bigger picture rather than just the tilted axial cuts or what have you. So looking at this, I think this is very helpful for me, and especially in planning and saying, okay, what is this fragment and how am I going to address that particular fragment?
Yeah, and Andy, I think that's when I see a fragment like that, this is no longer an olecranon fracture to me. I think of an olecranon fracture, the good old fashioned traditional olecranon fracture, is one where I'm not chasing that piece because that piece doesn't need to be chased because it's stable and attached.
Now, there are some questions in the chat box. I mean, Samir, yours was relatively straightforward injury that you were able to sneak a clamp around the ulnar side of the ulna to reduce that fragment. But any other, if you need to approach this more directly, any tips or tricks, Andrew, as to how you reduce that?
Yeah, so I think, again, it's looking at this. Usually these large basilar coronoid fractures are hopefully fairly simple, and hopefully they do have a read distally, and so this one does. And let me see if I can bring up my highlighter again. Sorry. But if you look at the course of the collateral ligament, it's very important to realize that this is your sublime tubercle, and the MCL, the intermedia, the MCL is going to insert here, and so you can safely dissect pretty much from here down just by elevating the FCU, the ulnar head of the FCU right here, and you can actually see this reduction and clamp this reduction, and usually that will bring this part back. I mean, if all bets are off if this becomes significantly more comminuted, but as of right now, this is something that you can usually address just from a posterior approach. When I was sort of more inexperienced at these, I would often prep and at least mentally be prepared to have to approach this from a separate medial approach. But I typically for these, you would say maybe an FCU split approach, and when you're doing dissection for it posteriorly, you're oftentimes dissecting part of the FCU off anyway. And I think you can readily get to this fragment pretty reliably.
And
the other question is, do you need a sorry,
when you sequence that, are you doing that first before you're fixing that more proximal fracture fragment of the ulna, or are you, I guess, to access it, is it easier for that distal ulnar shaft to be quote unquote unstable so you can manipulate it a little bit more?
Just as a general rule, whenever I have a very comminuted proximal ulna, my rule is start from distal and work your way proximal. And that's typically what I'll do. I don't think it necessarily matters so much in this case, but I find it much more helpful to try to restore the shaft of the ulna starting from distal and working my way proximal, with the dominant primary olecranon fracture line being the last thing I usually do. So usually I'll find that more helpful to do that, to address this before the olecranon.
And then just before you move on, Andrew, a question in the chat box: any role for MRI to assess for ligamentous injuries here? We've talked about 3D CTs and knowing where those ligaments are, but is an MRI helpful in either of your practices?
I think for me, the only thing harder to interpret than a non-3D elbow CT is an elbow MRI. And so I will look at elbow MRIs where there's like essentially a known ligament injury, and I still have a hard time convincing myself. So not for me.
Yeah, I would agree. I barely get a CT, or not frequently get CTs. So an MRI is, I agree, out of the question. And the other reality is that I'm going to be dynamically assessing that elbow when I'm done. And I'm going to be there. So I'm not leaving the OR with an unstable elbow.
Perfect.
So I don't want to belabor the point, but what do we call this injury? And I would just take a brief aside. Chad, please stop me if I'm taking too long. But speaking about coronoid fractures, I think this is the old Reagan-Mori classification, where it's just sort of based on the amount of the coronoid involved. And I think that we've gotten a lot better and a lot more sophisticated at what these are. Just remember, these don't occur in isolation. Any coronoid fractures are fine that something else happened with the elbow. And the morphology really correlates with the injury pattern. And this is the O'Driscoll classification, which type 1 is a tip fracture, type 2 is anteromedial, and the type 3 is a basilar. And I think this is a helpful concept that really changed the way I think about coronoids, and they're associated with injury patterns. So your type 1, your small tip fracture, these are associated with elbow posterior lateral rotatory instability, sort of the classic elbow dislocation or a terrible triad. The type 2 fractures, the anteromedial facet fractures, this is a different injury pattern. These are associated with the varus posterior medial rotatory instability pattern. And then as per O'Driscoll, these large basilar coronoid fractures, this is usually associated with what he described as a trans-olecranon. Again, not to get too much into the nomenclature. But this is something I try to teach my residents and sort of drill into their heads and say, listen, if you look at the coronoid, there's patterns associated with that, so try to think about that when you're identifying them. So just going back to the case, surgical plan positioning, we can talk about approach, sequence, and then implants. I tend to do this kind of a thing, and if I did this now, I would do this prone. I remember the patient in particular, her exact body habitus, and when I went from going lateral to going prone, she was about as wide as she was tall, and with very short arms, and I found getting lateral imaging very difficult. So I would typically do these prone now. Again, if you think you might have to go anteromedial or sort of lateral, more direct lateral to address either a radial head or a coronoid where you may have to actually buttress it, I sometimes would err on going supine if I think that's going to have to happen, just because for me, it's easier to get to those places in the supine position. However, the trade-off is it makes your olecranon fixation harder. So this is what I did. You can see we have this clamped. We have independent lag screws into that coronoid fragment first, and then I'm addressing the olecranon fracture. You can kind of see the outline of this clamp, which is just like kind of like the ones that Samir brought up, except this is pre-made, pre-bent like this. So fix the independent coronoid fracture fragment and then reducing the olecranon. And then this is my sort of preferred construct for olecranon fixation, which is just a straight mini fragment plate that I contour myself. And I think the benefit of this is that it's lower profile, and I feel less bad about the damage I do to the triceps. It just has a smaller footprint.
So Andrew, that mini fragment plate that you have on there along the side of the bone, is that something that you've put on as a reduction aid, or is that an afterthought to beef up your dorsal plate?
It can be either. So if if the fixation is tenuous and you're not quite ready to put your dorsal plate on, you can actually add one of these on either side, either radial or ulnar, and just sort of bridge everything and have it be almost sort of like an internal fixator. Just hold your length out while you apply your dorsal plate. Other cases that you just have a lot of comminution, perhaps on one side or the other, and you just want to add some supplemental fixation. So it can be used in either manner.
And Andy, I see you using that long screw going down the intramedullary, going down the ulna. Some people call that a home run screw.
Yeah.
But you've done something unique with that. Can you tell people what you've done and why that works so well for you? Because I've traditionally gone away from using these home run screws.
Are you talking about the little bit of the bend at the tip of that screw?
Yes, sir.
Yeah. So this is the longest screw they have in the set. It's an 80mm screw, and this I'll teach my residents. This is the opposite of trying to put in a bicortical medial malleolar screw. When you hit that far cortex, you just want to high speed, slow advance. You want to etch the bones to make sure you don't just direct intramedullary. This is the opposite of that. I usually say go and oscillate and push just down the canal, and it should essentially the screw will follow this path. These screws are thin enough that they're flexible, and when they hit that anterior cortex, it'll actually give you great fixation, great purchase in this. So.
I think it's a really good point. I've never understood the purpose of the home run screw. I see people put these screws down the canal. That's like throwing a hot dog down a hallway. I mean, it's got zero stability, zero benefit from a mechanical perspective. And I wanted to point this out because it's a really nice, elegant trick that you've shown, kind of having that screw have that interference fit on that anterior cortex. I'll sometimes use a 3-5 screw just because I have to come longer off the pelvic sets that we have, and same exact thing. I'll have that thing sort of bounce and undulate down the canal, but getting interference every cortex it hits without going through the cortex, mind you. Yeah.
So this is the completed construct. And one thing I always emphasize again is that you want to check, even though you think that this is not going to be unstable based on the bony injury, I always test for instability under live floor at the end of the case, full extension, make sure I don't see any subluxation, any gapping, and this is the sort of the final construct in the operating room.
A couple of things, Andy, I want to point out that I think are subtle but really important. Your screws going from medial to lateral are not in your PRUJ. Ask me how I know that one. And so that's, I think, a really important. And you've got a beautiful AP shot, which I don't use a lot, but I'd use it to make sure that there's nothing in the PRUJ. And then on your lateral, if you can go back one image because of the overlap between I just want to point out how much fixation you've got in your proximal segment. You've got those smaller screws. You've got that, I call it a kickback screw that goes from distal to proximal. One of the things, again, that I think is really important in these particular injuries, even more so than maybe an olecranon, is because of how high energy they are and how sometimes small those proximal fragments can be. Having a tremendous amount of fixation in that proximal segment, I think, is really important. And you show it really nicely there, where you've got those smaller screws, plus you've got that kickback screw, plus you've got the surface of the implant adding friction. You get really good, stable fixation of that proximal segment.
Thank you actually, one of the other benefits of bending your own plates is that for very, very proximal olecranon fractures, I will actually contour a plate and I will bring it as high as I can, and I'll actually make a hook plate. I'll make tines out of it and grab the very tip of the olecranon and then contour it down and then back it up with sutures. But that's another way of just maximizing the footprint on a very small proximal segment.
So Andrew, you've shown now when you do your examination that this injury is still a bit unstable. questions about how do you get there if you've done a posterior approach? How do you get to a Coker or Kaplan interval to address the lateral collateral ligament injury? And then do you do an examination under anesthesia again after you fix your ligament?
So if it's, so you're seeing generally, you can see the insertion of it through the standard posterior approach if you do a careful dissection. And again, I would say that you should look at your preoperative imaging and make sure that there's not a separate fragment that has the insertion on it. If you haven't stabilized that, that can be a reason for instability. But if I stress this as I did and it was unstable, then I would essentially create a lateral flap and then do either a Kaplan or a Coker, your choice, and find the instability and repair that instability. After I do that, I usually do stress it again just to make sure, but I'm not trying to pull my fixation apart. I just sort of like to document and prove to myself that I actually made a difference and made it stable. Also for postoperative rehab purposes.
And then looking at your plate on the AP view that you have there on the right, I mean, this is one that you've contoured yourself. I note that the plate's not straight. Can you comment on that?
Yeah, so I've done this enough now that I feel like I know that when I have a certain length, I'm going to have to add this bow. And you're right. And one of my partners loves to say that one of the greatest myths that lies in orthopedics is that the ulna is a straight bone. Because it's definitely not a straight bone, and you can see sort of examples of the curvature of the ulna. It has the dorsal angulation, or the puda, as you can see in the bottom right there, but it also has sort of an apex radial angulation, and the further along you go down the shaft, and if you put a straight plate, you're going to be sad the longer your plate goes. So you have to sort of plan for all of that and be able to contour if you're going to use a non-pre-contoured plate for that.
And that dorsal plate you were using was a 2.7?
Yeah. 2.7 recon plate.
Perfect.
So here we go, some post-op images, 3 months, everything's looking good, nothing has failed. Elbows maintain reduction. And at a year post-op, doing well, healed fracture, satisfied patient.
Great, some very elegant cases, gentlemen. Thank you. I think those show some great teaching points for these trans-olecranon type fractures, but I think we've seen how there also can be some similarities and some overlap with the Monteja fractures. So if you can exit out of there, Andrew.
Gotcha.
That brings us into our next section where we'll switch gears a little bit and switch order. So Andrew, we'll get you to lead off again, but now we're going to transition more into those Monteja fracture variants, where we see more of a distal fracture of the ulna, often more comminuted and typically involving a posterior dislocation of the radial head. Again, we'll see some variants of that. So Andrew, if you could go ahead and lead off.
Okay. So we'll move right into the second case, and this one, things get a little bit more complicated. So this is a 48-year-old guy who tried to jump off his roof into the pool and missed, unfortunately. In addition to a femoral neck fracture and a calcaneus fracture, he has this injury.
Never understood why that's a good idea.
That's one of the hold my beer, watch this, hold my beer moments, you know?
What could possibly go wrong?
So he gets a close reduction attempt, which I think is a good thing to do. He gets splinted and things look a little bit more recognizable, but still clearly a lot going on.
So after that reduction maneuver for you two, like, is this a surgical urgency now? Can this still sit in that dislocated position? What's your sense of timing when you see this?
Well, I can tell you for this particular patient, again, he had a femoral neck fracture, which took priority for sure. I think that I don't think I tried a repeat reduction attempt. I said, is the skin okay? Is it at risk? Is it blanched? And the answer was no. And so I said, okay, we're just going to kind of keep this in relative extension so that there's not too much pressure on the posterior skin, but we're going to address this femoral neck first and get back to this when we have a few hours of our life to dedicate to it.
And Samir, what about if the nerve's out or if there's some other concern? Does this get you in at night, or is this one still going to wait for your elective day on Thursday?
Yeah, I mean, I think If the nerve is out and it looks like this on the lateral, so it's still dislocated, I think this becomes the first case of the morning kind of thing. I mean, if it comes in during the day and I'm there, I'll do it. But if like it's 8:45 at night, like it is right now, and this comes in right now, and I'm not on call, but my partner is, if he's not going to do it, I'll take it first thing in the morning and I'll bump whatever else is going on to get it done. Yeah, I would do that if the nerve is out and it's dislocated like this.
I mean, just one other, I'd make one comment is that this is a complicated case and you need to do a little planning before. And I don't think you're necessarily doing a patient a better service by rushing them to the OR without a good plan because you're worried that the nerve is out. And when again, I think for the most part, I don't want to dismiss it too much, but a lot of the nerve injury, the palsy is going to happen with the energy that went through this fracture.
Yeah.
And there certainly could be a role of an evolving nerve injury or that they're still under tension and you can help that. And I certainly would say that that's a situation you want to do something more acutely. But by the same right, if you go rushing into the OR for this kind of a fracture without a good plan, without thinking about it, I don't think you're doing him any favors either.
Totally agree with you, Andy. This is not a case that like I said, I would do it first case, but I'm thinking about this case. Like I said, if I get a call about this at 8:45 at night, I'm thinking about this all night into the morning, planning ahead. And I've got my team as well in the morning. I've got my implants at my hospital. I've got the right fluoroscopy tech. So I think all of those pieces are really important. This is one of those light of day type cases. I want to be fresh and ready.
Yeah.
Perfect.
So again, because I like CTs, here's just the sort of the 3D reconstruction.
Andy, when you say you like CTs, you like these 3D CTs. You don't like the axial CT of this, right? The axial CT of this is nonsense.
Yeah, it's very hard to tell what's going on. But yeah, that being said, you can also sort of gloss over some things with this, with the the volume rendering images. But I think this is very helpful, big picture overview of what's going on.
So Andrew, some questions in the chat earlier for the trans-olecranons, and I think it applies probably here more with the Montesias. When you see that anterior coronoid fragment there, when are you thinking I need to make a separate approach for this, or I can approach it from the posterior aspect by sneaking a clamp around like Samir talked about, or when are you using alternative exposures?
I think at the beginning of my career, I worried a lot about having to go and do an anteromedial approach and buttress this. But at this point, it's becoming a lot more unusual for me to do that. And I feel like I can usually get the fixation from the dorsal side. That being said, I'm always mentally sort of prepared to do that if I have to. If it's a completely separate, just anteromedial facet fracture that has the insertion of the interband of the MCL, then I'll probably be more inclined to try to consider going for a separate approach. That being said, you can still actually get that from the dorsal side if you know where to aim your screws from your dorsal side.
And are you routinely dissecting out the ulnar nerve here like you would for a distal humerus, or are you more staying on ulna and working around the flexor?
I'm not typically completely dissecting it out and exposing it unless I'm going anteromedial. So I think there's a number of challenges in this one. You can see that the coronoid is not just one simple large fragment. There's actually a separate coronoid tip fracture. There's a radial head that's comminuted along with the radial neck fracture. And so I guess, I don't know, what would you guys say that, what would you classify this injury as if you had to classify it, or a resident called you, how would you like them to describe this one to you if you can't see it?
Samir?
Yeah, so I mean, this is where I start to struggle a little bit because if I was asked how to describe this, I would describe this based on the fracture fragments that I'm seeing, the pattern of the injury. When I look at this, I know what I need to do. I need to give this guy a stable elbow that can move essentially immediately or near immediately. I know that I have to reconstruct his olecranon and his coronoid. I know I need to do something with his radial head, and I know I need to get him reduced and keep him reduced. And so the goals of care, I know we sometimes get caught up with, what's the classification, and I have to make sure that he's ligamentously stable. And so we get caught up in the classification scheme sometimes, but I'll be devil's advocate and say, someone described to me, when I say someone, my resident or whoever, describe to me what you're seeing. You can call this a trans-olecranon fracture dislocation, a Montesia variant, a complex proximal ulnar radius fracture. But at the end of the day, I need to understand what those pieces are, what's attached to those pieces, and what I'm going to do with them.
I think that's a great answer.
In comparison to the previous cases that we've seen, I think this one more follows what the typical description of these Montagian variants are, with that posterior or posterolateral dislocation of the radial head. We see the radial heads involved. It looks to me like the proximal radial ulnar joint is disrupted. So this has features that would make me classify this more as a Montagia variant, but I agree totally with Samir that I'd rather you be able to describe to me what you see on the x-ray and what the injuries are that you identify, as opposed to being able to classify it. So I think that's absolutely correct.
So again, looking at this, I did spend quite a bit of time sort of planning this and sort of thinking about the position of this patient, the approach for both the radius and the ulna, what implants am I going to have available in the need, so if I'm looking for booking this case, and then what order am I going to address all of these in? Radius first, ulna first. Give everybody 20 seconds to kind of look at this and sort of think to themselves, what are they going to do?
Where's the call Andy option? Is that the next bullet point?
Unfortunately not. You don't need to, Samir. I know. I see your work.
Ship to Houston. Oh, that's the backup plan. There we go. Yeah, ship to Houston. That's where that goes. So.
So one approach that I found very helpful, this is from Dave Fuller at Camden. This is the Trans-olecranon surgical approach for radial head arthroplasty. He doesn't, and he described essentially what he just is called a shotgun approach. You hyperflex the elbow, and because we know that this was posteriorly unstable, you can deliver the radial, the proximal radius, the radial head into the wound just by using the instability provided by the ulnar fracture. In this image, it's a little hard to tell, but he's actually sutured the coronoid tip as well as replacing the radial head just through the wound first thing. Now we can talk about the challenges that creates, but I think this has been a very helpful option for me for these kind of injuries. So this is what I did. I did this one. You guys didn't think I'm crazy, but I did this one supine because I wasn't sure that I wasn't have to go anteromedial to buttress the coronoid. And in doing so, my initial plan was actually for a radial head arthroplasty, but when I looked in there, there were essentially large pieces of the radial head that I could put back together, and I could see the radial neck fracture line, and I could put that back together. And so I said, okay, why don't we try to fix this rather than just jumping to a replacement in a 48-year-old? And the reason, again, that these images look so funny is because this is a supine position, this arm's over a bump, and he's hyperflexed. So just checking my radial head screw position, making sure I'm not long, and then I use sort of a tripod configuration for the radial neck fracture.
So Andrew, when you see these radial neck fractures like this in a, middle age, I forget what age this patient was, but he's young. How do you decide, are you going to try to fix this, particularly when the radial neck's broken versus going straight to arthroplasty? Do you have any rule of thumb?
So, I mean, I think I do stand sort of, I've been using the old standby of the ring Jupiter greater than 3 fragments tends to do better with the arthroplasty. I think that I've seen even 2-part radial, just a radial head and a radial neck, just with a radial neck fracture that's comminuted with bone loss. I've seen those not do well with fixation either. So I've gotten a little bit more lax with doing an arthroplasty in those situations as well. But it is definitely a case-by-case basis. I do think age plays some role in that. I don't love putting a radial head replacement in a very young person. Sure. But if it's the difference between a stable elbow, again, I think I'm doing them a better favor by just giving them a stable elbow and a stable radial head if I have to.
Yeah, that radial head replacement's in the room or nearby as a backup?
It is in the room. Yep.
Yeah, I would agree with that. I've actually probably shied away from fixing these. It's not a load-bearing joint per se, the way a hip or a knee or an ankle would be. And I think part of my decision making is the amount of chondral damage. So they can have 2 fragments, but if one of them's been sitting dislocated and in the soft tissue and there's a lot of chondral damage, what's the purpose of restoring that? Part of that is also sometimes visualization. I'll take advantage. I know we're not talking about terrible triads, but I'll take advantage of a relatively bad radial head and excise it so I can see better, especially if it's in the way of what I need to do. So I would agree with Andy. I've gotten lax over the years in terms of trying to fix some of these rather comminuted ones, or even ones that are maybe not as comminuted, but high energy and clearly would, if it was any other joint, I would probably replace it.
Now, if it's really comminuted, what about just excising it?
Yeah, I think excision in a situation like this can be problematic, particularly because I think you need every opportunity to stabilize the elbow. And while the radial head is not a quote unquote primary stabilizer of the elbow, there's enough secondary opportunities you get with it that I would discourage people from excising it, particularly in the setting where there's concern about ligamentous injury, especially if you're not a great ligamentous reconstructor of the elbow.
So this is our final fixation for the proximal radius. And then the nice thing is actually when you reduce that, you actually have a strut to get length for your ulna. But one thing I'm just going to sort of bring up, I harp on my fellows about this all the time, is that when you're looking at these images and these nice 3D CTs, you have to start to think about more than just the bone. You have to think about the soft tissue. And so when I'm looking at this, I see this fragment. I see that this is the sublime tubercle, and this is the course of the anterior band of the MCL, and I know exactly where it inserts, and it inserts on this fragment that I'm going to need to address. And on the lateral side, that's the supinator crest, and I know the LUCL is going to insert on that fragment, and I see it's a separate fragment, so I know I'm going to have to be very, very cognizant to address that as well in order to restore elbow stability, not just bony stability. So again, sort of a dual mini fragment plate construct. I worked from distal to proximal, gathering all these sort of the simpler fragments, the simpler fracture reeds with independent lag screws. And then again, my sort of standard dorsal plate, 2-7 recon. Again, just stress the elbow even after you're done. Make sure that you've addressed all the potential instability. Make sure that the elbow is stable. That changes the rehab significantly for me. And this is the final construct.
It looks fantastic. Interestingly, I see your mini fragment plate now is on the radial side of the ulna as opposed to the previous case.
Yeah, I would say there's not necessarily a rhyme or reason. If you're on the ulnar side, you do have to be careful that you're not shooting into the PRUJ, which is very easy to do. So typically I'll go on the radial side, but if there's one side with more comminution than the other, I will often put it there too. If there's I want to put this plate over a separate fragment, I will put that sort of to help buttress that as well.
And I like this trick. I've used it on both sides like a sandwich.
So the last view on the right is the one Samir, I think, was talking about a little bit. This is the view to make sure that you don't have any hardware in the PRUJ, and it's sort of an externally rotated view. It's very important to get before you're done, in addition to sort of ranging the elbow, supination, pronation, flexion, extension to make sure that you're stable and that there's no crepitus from intra-articular hardware. So here he is at 3 weeks post-op. Things are looking good. He's moving his elbow. His wound is healing. No complaints. Of course, nothing ruins good results like follow-up. So here he is at 4.5 months. He really isn't complaining much. He's still moving. His range of motion is getting better, but I'm starting to get concerned, especially because I see one of these screws backing out. And I see signs that the radial head really isn't, or the radial neck, excuse me, rather isn't really doing a whole lot of healing. So I guess you guys were right. I probably should have been a little bit more aggressive with the arthroplasty.
I must say, I mean, your initial post-op films look great, so I would not have predicted this.
Do you guys use this cross screw configuration? I know we're not talking strictly about radial necks or heads, but are you platers or sort of this more of this tripod screw configuration?
Yeah, I'm a plater. I'll show a case coming up where I like plate fixation. I think you have to be smart, as you'll see that I wasn't, where and how you apply that plate. I think the distinct advantage here with the tripod configuration is you don't have any surface implants that can be problematic. And you're not getting onto that surface of that radial shaft where you have PIN, where you have to be mindful of your soft tissue management in your dissection.
I think this is a very elegant technique. I agree with Samir. If I have to fix them, I'm a plater, but I dislike plates. And if I have a radial neck, it is very often going to be looking at an implant as opposed to a fixation.
You know, the primary reason that drove me to this in this case was actually because I was doing that quote unquote shotgun approach where the radial neck is delivered and the head's delivered to me, and I don't have to do any dissection down the neck. So I literally just fix this because I'm looking at it from that view. And so,
so
that's
Andrew,
what drove me to this.
Maybe we can move on to Samir's case. I think he's going to show a very different outcome here. And
Sounds good. So here we took him for a radial head arthroplasty, and then here he is at 9 months post-injury.
Great case.
All right. Share screen.
So while Samir's loading up there, Andrew, a question that came in: if your proximal ulnar fracture extended more distally down the shaft, would you still use that same posterior interval? Do you need to switch to a different interval to address the radial neck as it extends more distally?
Yeah, I have a different case of that, and the answer is usually you have to then use a different interval just so you can dissect out the PIN. If the LUCL is intact, then there's going to be a difficult, you can't use the shotgun approach to go distal, even for a short radial neck plate typically. So if you're going to have to extend down, then you're probably going to have to use a different interval.
So that shotgun then more for fixing radial head or radial head arthroplasty?
It is. The one exception is that if you have a fragment with the LCL insertion, you can actually reflect that out of the way and then plate further down the radial shaft. But if you're going past the level of the PIN, you should probably just do a separate approach.
Great.
And that brings up a really nice transition to this case, because this is a 61-year-old female who's right-hand dominant. She happens to be an occupational therapist, which obviously increases her risk factors tremendously because now she knows she's going to have a complication. And I believe, I forget the mechanism, walking her dog, fell down the stairs, something to that effect. And that's her AP and lateral image in the emerge. She did get a CAT scan. Again, I've sort of shied away from the use of CAT scans, but this one was obtained by the ED, and then I was able to generate my own 3D images via whatever computer software program we have. And you can see the sheer amount of comminution here of the ulnar shaft and proximal ulna, which I think really makes this somewhat challenging, along with that radial head component. So just to keep things moving, so this is, I think, a critical error on my part. I placed her in a lateral decubitus position, similar to the images I showed earlier, and I went posterior and realized that fixing this, which is what I wanted to do, because as I just talked about how I've transitioned to replacing these, this is a fairly it's a radial neck fracture. The radial head is actually intact, and I do have otherwise, and it's minimally displaced, and hasn't been sitting dislocated, and it's not sitting in the triceps fossa or something like, or the olecranon fossa or something like that. I felt somewhat awful with the idea of throwing the radial head out. And so I had to fix it. So I had to do a separate lateral exposure, a Thompson exposure, to get access to this. So now I'm doing this in the lateral decubitus position, but I'm making a lateral incision, separate lateral incision from my posterior incision for the olecranon. And it was a little bit challenging doing that exposure. And Andy sort of talked about that. But I also know that my trying to do this in the supine position and do my lateral incision supine on an arm board, which is relatively straightforward, and then bringing the arm over the body like I'm doing is also not, I'm going to do a disservice to fixing her olecranon. So this is, maybe I should have repositioned her. I made a mistake here, I think, and I think it affected my ability to put this plate on in the appropriate location for this patient.
Andrew, any thoughts about that or tricks?
Yeah, I mean, I guess what made you, if you're going to do a separate approach, what made you decide to fix the radius first? Because in some way in the back of my mind, I think maybe if I knew I was going to have to do a separate approach, maybe I would have just fixed the ulna first. And then if I had enough stability with the ulna and the radius was relatively well aligned, there would be part of me that would be tempted to just leave it alone. I don't know if that's the right answer.
Yeah, no, that's a great question. A part of my reason to do the radius first was her olecranon is, I mean, it is very comminuted, and I as you know, I'll go after these small fragments. She's also a bit osteoporotic. I was concerned about my ability to get her ulna right without having her radius out to length. And maybe her radius is a touch short. I don't think so, even though it's not a great reduction of her radial shaft, radial neck, radial head. I think I got her radius out to length, and I thought that was going to help drive my ulnar reduction, and that was my rationale. Similar to the case you just showed, right? You got that radius, radial head, neck out to length, and that helped get your length back, right? Because at the end of the day, and again, I tend to want to anatomically fix these, but this is one where I was considering, because of the amount of comminution, bridging this fracture as long as I could get a stable elbow, get the articular surface reconstructed, and then all that comminution, just bridge it. But I would need to be out to length, or I'd have a potentially subluxated or dislocated radial head.
Yeah, the difficulty is that the radial neck is even not that straightforward. It's comminuted as well. So
right,
neither one of these are easy fractures.
Yeah.
So I then used, I know I've been using these, this is a pre-contoured plate. This one has tines on it. I don't, you can make your own of these, and Andy even mentioned making his own. Again, this is prefabbed, but I use that to help capture that posterior fragment, and then some clamps. But my idea here was to bridge this. As long as I could restore her articular congruity, the rest of her ulnar shaft really doesn't matter to me. I mean, I don't want to be mean about it, but this is what I care about, right? I care about this, and I care about my radial head, and everything here where my laser pointer is almost irrelevant to me for the most part. I say that somewhat tongue in cheek. Obviously, her soft tissue attachments, et cetera, are important as well. And so this is her reconstruction. And at 5 months, she's got supination to neutral, pronation to 45 degrees, and very limited flexion and extension. And she's an occupational therapist, so she's miserable. She can't go back to work just yet, and she's having a lot of pain, a lot of difficulty. And you can see that, and I don't know why I didn't appreciate this, because I do what Andy does, which is I go through a full arc of motion in the operating room. I stress my elbow. That proximal radial plate is not in a great location. You can also see some of that radial head, which I don't know if that was also impinging, but I was not really happy with her clinical outcome. So I guess my question for you guys is, how soon do you take these elbows back when they get stiff? Because I think we'd all be lying if we didn't say some of these injuries don't get stiff on us.
Yeah, I mean, if it's, sorry, go ahead, Chad.
I was just going to say, I think you have to look at the case whether they're laying down a ectopic bone and it's a bony block, or if it's purely soft tissue, where more time and more stretching is going to be helpful, versus if it's a mechanical block from your hardware, where that's not going to necessarily get better unless you do something to change the treatment. So here, if I thought the radial neck plate was restricting her forearm pronation supination, I might be inclined to act a little bit sooner than if it was more just a flexion extension issue where I don't think there's a mechanical block. Andrew? Yeah,
I totally agree. So I think that if you see HO and the HO is the reason for the block to motion, there's no reason to wait. You don't have to torture the patient. You don't have to wait till their bone scan is no longer lighting up, and et cetera. You can go after that early. If it's pure soft tissue, then I will usually try to keep them with static progressive splints and therapy, et cetera, for 6 months before I pull the trigger on an operation. But
okay. So at 5 months, I took her back. I went through my lateral exposure that I had used, and this time I did it supine on a hand table, which made me realize how challenging doing this in a lateral decubitus position was, because it was much more straightforward doing it lateral. Going lateral in the supine position. I removed that plate. I actually debrided the radial head, took down this bone that was by my laser pointer, and this is her at 2 years. She came back to see me actually this past week. Let me see if I can play this video, because the olecranon plate's bothering her at this point, and she wanted that removed, but otherwise is back to work and doing actually well. You'll see the video here in a second of her motion. The left arm is the involved arm. And so really her
always good on the video when you have to point out which arm's injured. So it's always a great indicator of your results.
You think that's partly because she was an occupational therapist? Other than your
So
excellent fixation.
yeah, no, I mean, I think she knew all the exercises to do, but she was a very nice woman, but not the best patient. What I mean by that is definitely, started off. We didn't start off great in terms of her pushing through some of the pain and pushing through. I mean, I tell my patients to be very aggressive early, and she was not. There's definitely some of that, but once she got going, she did great. And I think, yes, I think her knowledge base probably helped her with this outcome.
Looks great.
Yeah. So hopefully it all stays together when I take her back and take her hardware out later this week. All right. This is our next case. This is a 68-year-old pipe fitter. This is his left arm, but obviously he needs both arms to do his job. Still working. Big man also. He's a big, burly, kind of stocky, strong, muscular kind of guy. I don't know why I put that one on backwards or upside down, so I apologize if all of you are now rotating your head to look at that. So a complex elbow fracture dislocation, I mean, a trans-olecranon, Montesia variant, I'm not even sure what to call this. All I know is that this is going to take me a while to fix. It's very comminuted. Here's another picture. This is a traction view. I know we haven't talked about traction views, but especially in this injury pattern, I really feel like it gives me a ton of information, maybe even more so than the CT, because now I can see my radial head very clearly, and I can see that, at least in my hands, I'm not attempting a radial head reconstruction in a 68-year-old man. I'm not doing it. Not with that. Not that looks like that. Maybe if it's Chad's 68-year-old elbow, I'd consider it. Is that how old you are? 68 yet? No.
Yeah, not quite.
Right.
Another year, Samir. Thanks.
But I'm
And
not.
we'll be wrapping up now for this evening.
But this is one that I don't think I would attempt. I mean, Andy, I know you like to. Would you fix this one? You think, or no, based on this traction view? Yeah.
No way. No.
And you can see his coronoid is sort of sitting out here, and so to me, this is a really challenging case. This is the CT that the ED got. Again, the thing that has me concerned is the coronoid itself is also comminuted. It's got some multiple, so I start to get a little concerned about how I'm going to reconstruct this and getting access to all these pieces. So I took him to the operating room, again, lateral decubitus position, posterior exposure, and similar to the X-ray or the article that Andy showed, I did use that quote-unquote shotgun exposure. I worked through the fracture, and I think it's a great way to get access to the radial head. In this case, I knew I was doing an arthroplasty, so you flip the olecranon up, and you're staring at your fracture fragment. You can also do a Boyd exposure, where you can take the soft tissue down off the olecranon or off the proximal ulna and see the radial head posteriorly. So you gain access to the radial head. Now, this is the challenge. You can't just put any random radial head in because you don't have your ulna out to length. And so what I'll often do is I'll put the trial in, then I will repair and reconstruct my ulna so that I know what ulnar length is going to be to assess the quality and the position of my radial head to make sure I'm not overstuffed or understuffed, if you will, my radial head is right. Then I take everything apart and put the actual implant in. So that's probably the downside of doing it this way is instead of fixing the ulna and then trying to put the radial head in through a different exposure, I'm sort of torturing myself by fixing everything with the trial in, then taking it apart and putting the actual implant in. And that's what you see here now is I've done the trial already. I took everything apart. I put the actual implant in, and now I'm going back again to fix my ulna. The only advantage I have is I fixed it once, so I know I can fix it again. So I try and remember the steps and follow the breadcrumbs the second time through.
So Samir, a couple of questions have come in throughout the chat with this. So I think that's a great point is using that shotgun approach, put the trial in, do a provisional reduction of the ulna, as painful as it is, and then use that provisional reduction of the ulna to assess your radial head size. But do you have any tips on how you determine that size? How do you know if it's overstuffed? Any tips on sizing that radial head based on what you see here?
So obviously you start with the radial head fragments that you excised or removed and get an idea of what your radial head height is going to be. And then I will start with And then I also try and assess how much of my neck is, if you will, gone. And then I'll build up my trial based on the radial head height and size and the amount of radial neck that's been injured. And then I will put it in. I also get an X-ray of the other elbow to just get a rough idea of what we're talking about. It's not terribly helpful intraoperatively, other than sort of having an idea of what things should look like. But it is a little bit of trial and error. And so then once the radial head is in, now I've got my length somewhat restored, and now it does make my olecranon reconstruction a little bit easier. You'll see here multiple point-to-point clamps, the modified point-to-point clamp that I showed earlier. And then you'll see here that, you know, it's reduced on the picture on the right, it's dislocated on the picture on the left. And I'm like, well, am I done something wrong? Is my olecranon short? Or am I malreduced? Is something driving this malreduction, or this subluxation? And obviously the first thing you should be thinking of, as I am as well, is there another soft tissue injury somewhere? What I will sometimes do is I will use clamps to clamp down on my soft tissue. I'll use a nice point of reduction clamp to capture my ligamentous complex and clamp it to the bone to see if that will help create stability. It's not perfect, it's not like doing a repair, but it gives me an idea. And that's what you see this clamp doing here in this picture on the right. This clamp is mimicking what, oh, you can't see because I'm not using my laser pointer, but this clamp that you see here is mimicking what a soft tissue reconstruction would be doing. Not perfectly, but enough to give me an idea if that's where my stability is going to come from. Again, this is a pointed reduction clamp that I'm using to pierce through the soft tissue, because that soft tissue is really robust. And then I am clamping it down to the bone to imitate or mimic what my soft tissue repair would be. And what was interesting in him, and Andy has pointed this out beautifully on the 3D image he showed what he teaches his fellows, which is that ligamentous disruption was off the distal side. And so I remind people that I'm obviously, many of us are used to having this come off the proximal end of the distal end of the humerus when we're thinking about terrible triads, but this is not a terrible triad. And in this case, the ligamentous injury was actually distal, not proximal. And you can see my suture anchors here restoring the soft tissue envelope distally, allowing or providing for that stability and the stress view after I did my repair of the soft tissue. And again, if I'd spent a little bit more time with this CT, maybe if I'd used a 3D CT, I may have recognized or realized that this I should have suspected this.
I agree, much more common to see it come off the distal humerus, but it's great to point out that sometimes the ligamentous failure can be off the ulnar insertion.
Yeah. And you can see, I don't think I got a great anatomic reduction of this. I got all the pieces back, and my screws that I was either using to lag or lag by technique, a lot of mini frag here or small frag. I don't think, but I did get, I think I got the articular surface reduced, and I got the elbow to be stable, which is my goal. I actually started him on range of motion 1 week after surgery. I just put him in a splint for 1 week. And this is him at 1 year. He's gone back to work as a pipe fitter. He's using this left arm. You can see my coronoid piece looks like it has escaped a little bit. And his range of motion isn't perfect, but it's good enough for him to be able to work. And he's not interested in any more surgery or any kind of further treatment.
That's a great outcome.
Can I just ask, so,
Yeah.
in my case and in your case, the coronoid was multifragmentary, segmental almost, and there was a separate tip and then sort of a basilar. And I ignored, that coronoid tip in my case, and that looks like you did too. I mean, is there any role does that need a suture repair? Does that need a separate approach? Does it need does it need anything?
So that's a great question. I don't know that answer. I will tell you that I think if there's instability and you fixed everything else, then I think you have to go after that tip piece and reduce it. In this case, I don't think I actually ever captured it. I thought I did, but maybe going back, would you say what's actually capturing it? Not much. I think this is the piece right here. I don't think I ever did anything with it. And there's definitely, again, I know we're not talking about terrible triads, but there are definitely terrible triads where I have fixed the lateral collateral, I have addressed the radial head, but I have not done a good job dealing with the avulsion or the tip of the coronoid, whether I've done it on purpose or unwittingly, recognizing it after the fact that I didn't do and those elbows do fine. In fact, I have some colleagues in the elbow world, I know you live in that as well, who sometimes suggest not fixing those tip fractures because it gives them enough quote unquote instability that they get their motion back a little bit better rather than suturing it down or tying it down and giving them a quote unquote tight elbow that they can't use. And so I think getting that tip makes me feel better. I'm not sure how much it's really adding in something like this.
So as we transition to the journal article, that's a great segue into a couple of questions that have come up in the chat. First is about intraoperatively, how do you assess stability? Is it the 30 to 130 degree arc that we usually think of as functional? What's acceptable for stability before you leave the OR? And are varus valgus stress views helpful on the AP view, or is it mainly, can you keep it concentric through an arc of flexion and extension?
So I tend to go full extension, full flexion. I tend to be very aggressive in patients who I don't think have a ligamentous injury that I have not repaired. So if it's a bony injury, I've fixed everything I think I've fixed, I will then take them full extension, full flexion, and I put them in, I take the arm because I'm doing it lateral decubitus. So I then put the arm, I told you earlier, I don't like to rotate the arm into a lateral position on that AP view, if you will, but I purposely put them into a lateral position, which creates rotatory stress on their elbow. And I take them through a full arc in that view and also pronate, supinate them on the lateral to see if the radial head subluxes. That tells me if they've got a soft tissue injury. And then if I repair their soft tissue, then I'm a little bit more tenuous and a little bit more particular about how I stress them, noting that I don't want to disrupt my repair and making sure I have a concentric reduction when I splint them.
Andrew, anything different?
Yeah, for me, it's primarily flexion extension, and it's usually extension is the position of most instability. So for coronal plane instability, I don't want to say I don't care, but if everything else is restored except for an MCL that opens up in valgus, I'm usually not too concerned about that. But if it's an LCL, I don't typically stress varus. It's usually just sort of a posterior lateral rotatory stress and extension. So I'm not usually doing all the stress views on the AP varus valgus so much.
Perfect. And then the final question is about how to deal with the stiff elbows post-op. Are either of you doing anything for heterotopic ossification prophylaxis? How soon do you want to get them moving, etc.?
Andy, you first. I can chime in if you want.
Yeah, I haven't found HO to be enough of a common problem that needs a secondary surgery for me to prophylax everybody. You know, there is a study out of Carolinas for about HO prophylaxis for radiation at least. And so I don't typically do anything in particular, and it's very hard for me to predict who might get HO and who will get HO to the point where they need another surgery.
Perfect.
Yeah, I don't tend to prophylax for HO unless I'm doing a revision, HO excision type thing. And my goal is to get them moving as fast as I can.
Great, I agree. So just to bring this home, no Fireside would be complete without some literature review. And, we spoke about this as a group, and, the literature that deals with Montesia fractures and trans-olecranon fracture dislocations is not fantastic. So we thought we would briefly touch on this classic paper that I don't know about you guys. I don't know that this would get published in today's literature with today's standards. But I think this was at the time sort of a pivotal paper for our understanding of this injury. This is from JOT in 1991, the lead author, Jupiter. And they published on 13 cases of posterior Montesia fracture dislocations that they identified as being a little bit different than that posterior dislocation that Beto identified, which was more of an ulnar shaft fracture. And they identified that this often involved either a triangular or quadrangular fragment involving the coronoid. So they had 13 of these fractures out of a collection of 18 Montesia fractures over an 8-year period. So this was out of a large population of injuries seen at an upper extremity referral center, and still over 8 years, they only had 13 of these cases, which I think speaks to its rarity. From studying these injuries, they came up with a classification which still stands today. We still use this Jupiter classification, and they describe the type 2A as being the more proximal fracture involving the ulna, the type 2B being slightly different distal, Again, you can see the comminution of the coronoid, but just distal to coronoid. The type Cs that they described, they actually didn't have any in their series. And I must say, it's not something that I have ever found to be that useful moving forward. But then the 2Ds are the ones that we often talk about. And I think a lot of the cases that were shown tonight tend to have more of this diaphyseal comminution. So these higher energy, more complex, more challenging fractures like we saw tonight. They identified that these fractures, unlike the Beto type fractures that tend to be in younger patients, these were often more elderly, predominantly female patients with more low energy injuries. Obviously, you can see them with high energy mechanisms as well, but not always. And the commonalities, I think, with their fixation, and we can talk about this a little bit different than what we might do today, but they plated all of the ulnar fractures using either a 3.5 millimeter DC plate that they contoured, a recon plate, or some third tubular plates. But with the radial head, only 3 of them were treated with open reduction internal fixation. One of them had a silastic implant, which we used to use for fingers and toes, but we certainly, I think, have discarded now for radial head fractures. And a scary number were excised, which again, as Samir alluded to, for secondary stabilizers of the elbow, I think today we would probably manage differently. But if you look at this series of only 13 injuries, they had great follow-up out to about a mean of almost 40 months. They had 3 cases of early failure of fixation, 1 that had a transient posterior interosseous nerve palsy, and a bit subjective, but the Broberg and Mori index, 3 excellent, 3 good, 4 fair, and only 1 poor. They described only 1 case of mild arthritis and had some heterotopic ossification. But I think what they identified as part of their study, and what has drawn our attention to this, is that even subtle ulnar malreductions led to persistent subluxation of that radiocapitellar joint and impaired pronation supination of the forearm. So again, it's sort of a classic paper that, again, most journals probably wouldn't publish today, but really provided us with some insight into this fairly rare and what remains, I think, as you've seen, quite a challenging injury. Comments as to what you like from this, what you've adopted that's different now in your practice, Samir, and then Andrew?
I would say that I think the acknowledgement and recognition that these are not traditional Montesia fractures, I think, is important. I think what you see now, at least, and I think you saw it really nicely on Andy's x-rays, is really good rigid fixation of these injuries. Understanding both the bony and the soft tissue component, restoration of that, not with, tension band wires or even minimal fixation, but really getting aggressive with the fixation strategies to get a stable base to work off of. I find these fractures to be high, even though they're low energy injuries in Jupiter's paper, I find them to be behaving like high energy fractures in terms of their instability pattern. And I think that's the critical part of this. So treating them like high energy is important.
Yeah, I think it must have been a pretty cool time for this back then, just to be able to see these patterns and then publish a paper on it, just on 13 patients. I think that's just because people weren't recognizing it. So I think that's huge. The associated injuries and number of radial head fractures are associated with this, I think, is a huge recognition that these need to be addressed differently, and these are more complex injuries. I do think it's interesting reading this again, just to bring it full circle for the confusion of the nomenclature, is that really, we talk a lot about disruption of the PRUJ defining a Montesia to a large part today, but this said nothing about that. This is really just, there's a posterior dislocation of the radial head and there's an ulnar fracture, and this makes it a Montesia variant, quote unquote variant, but because, it's Jesse Jupiter, so this is adopted widespread throughout. Here we are, 30 years later talking about it.
Right, and I think that's right. I think the classification scheme is really muddled. I think this Montesia variant, Trans-olecranon, posterior Montesia. I find it to be somewhat overwhelming in some ways.
So I think that segues nicely into our summary. So we've talked about two different injury patterns that all three of us struggle to really come to agreement on some of these cases as to whether they're Montages or trans-olecranon variants. The historical teaching was what that trans-olecranon fracture dislocation, the proximal radial ulnar joint was intact, whereas with the posterior Montagia, it was disrupted. But I think what we've seen with both of these injuries or this whole constellation of injuries is that the goals remain the same, that we want to restore the articular congruity, that we want to restore joint stability and be able to permit early range of motion to combat that stiffness that we've identified as a problem with all of these. And the strategies are common for both injuries. You're trying to restore the ulnar anatomy. With the trans-olecranon fractures, with that comminution in the trochlea, it tends to be more restoration of the trochlear notch and the olecranon. With the more distal injuries, it then transitions into more a restoration of the alignment of the ulnar shaft. You want to address the radial head injury. If it's fixable, you want to repair it. If not, you want to replace it. But I think all of us agree that for the benefits of the secondary stabilization, not to excise the radial head. And then assess the elbow for stability. Sometimes restoring the bony stability is all you need to do, but there may be associated collateral ligament injuries and you need to be prepared to assess those intraoperatively and to address them. Remember that the approach to some of these injuries is actually through that fracture. So before you reduce your olecranon component, think about using that shotgun approach to get to the coronoid, to get to the radial head, and then reduce the olecranon after you've addressed those other associated injuries. Remember, the ulna is not a straight bone. So if you're applying an implant that you're going to contour yourself, you have to put not only that ulnar bow, but also that proximal ulnar dorsal angulation to avoid mal-reducing your fracture. So again, as take-home messages, I think it's important that you evaluate your injury films critically. 3D reformatted CTs, if they're available, can be very helpful in getting your head around some of the subtleties of these injuries, identifying what's broken and which fragments you're going to need to address. Pre-contoured plates can be helpful, plus or minus mini fragment plates, but as you've seen, Andrew likes to contour his own plates. I think what's key there is that you have to get that anatomic reduction and have rigid plate fixation to stabilize it. And again, anatomic reduction of the ulna is key to restoring stability. If you're looking for a review article, I think this is a fantastic reference that addresses both the Montagia fractures and the trans-olecranon fracture dislocations by John Scalero and Daphne Beingessner. This is from JBJS Reviews in 2014. I think it nicely summarizes a lot about what we talked about tonight. Thank you for your questions. Thank you for your attention and your participation tonight. And most importantly, thank you to Andrew and Samir for taking their time to share their cases, their expertise, and their wealth of knowledge on this topic. So thank you both very much.
Thanks for having us.
This recording will be available afterwards, so you'll be sent a link to the recording about 24 hours after the webinar for all of you who have registered. Upcoming sessions on the 22nd, continuing on with the theme of elbows, will be distal humerus fractures, followed by triads on the 29th, and then moving into the lower extremity tibial plateau on July 6th, tibial shaft on the 13th, and then finishing out the series with atypical ankle injuries on July 20th. So please take a few minutes to complete the online evaluations. Again, thank you very much for your attention. Hope you've enjoyed the session.